Hello everyone. Welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for December 2017. Thank you for joining our presentation this month. Our presenter today is Dr. Kim Bennell. Dr. Bennell is a PhD qualified research physiotherapist. She holds the position of Redmond Very Distinguished Professor and National Health and Medical Research Council Principal Research Fellow at the University of Melbourne in Australia. She directs the Center for Health, Exercise and Sports Medicine and the Center for Research Excellence in Translational Research in Musculoskeletal Pain. Her research has focused on conservative management of osteoarthritis, and her work has influenced clinical guidelines and practice. And currently, she is the Secretary General of the Osteoarthritis Research Society International. And today, her presentation is The Patient Will See You Now, Managing OA as a Chronic Disease. Welcome, Dr. Bennell.
Thank you very much, and thank you everyone for joining, and welcome from Melbourne, Australia, where it's very hot today. So what I thought I'd do is talk about osteoarthritis as a chronic disease, because sometimes we don't think of it as a chronic disease like we might say for low back pain. And it is a chronic condition. People experience pain, chronic pain. They have a range of comorbidities that is associated with it, such as obesity, heart disease, diabetes, and so forth. And self-management is a key component of management, where education, exercise, and weight loss are really the cornerstone of management. So what I thought I would do is just really briefly touch on 5 points that I think are important in managing osteoarthritis as a chronic disease. And we'll go through those, as I said, with just some examples from some of the research that we have been doing here in Melbourne. So first I wanted to touch on person-centered care. And generally, most people, when you ask them what is person-centered care, they're able to say that it's where you take into account patient preferences. And that is indeed one of the pillars of person-centered care, but according to Pickers, there's 8 principles of person-centered care. And these include your access to care, coordination of care involving family and friends, physical comfort, continuity and transitions, emotional support, and also information and education, which is really a core component as well. So as I said, we often, again, may not give as much time to educating the patient and giving them information and so forth. And so I think, as I said, this is a key component, and we need to make sure that we are spending a lot of time doing this. And sometimes clinicians, such as myself, who's a physiotherapist, we like to put our hands on, and we don't spend as much time in doing the education side of it. We also think that the language that we use is actually very powerful, and it can actually either help promote self-management, or in fact it can do the opposite. And so, for example, if the patient comes in and the clinician puts up an x-ray like this, and they look at the x-ray and they say to the patient, look here, you can see there's bone on bone, the cartilage is all worn out, there's deformity of the joint, there's a lot of wear and tear going on here. What that says to the patient is there's nothing that they can do, the joint's worn out, exercise is not going to be good for this joint. So it sets up in their mind, you know, a bit of a feeling of helplessness, that there's really nothing they can do. They're just going to have to go and have a joint replacement. And so we really try and not use these kind of words when we're explaining to the patient about what osteoarthritis is. And instead, we use language such as that there's that normally the joint can repair itself, but there's a problem with the repair process, and you can get changes in the joint, and that can lead to the things that we see, such as pain and stiffness and so forth. Another key component of person-centered care is shared decision-making. And this really is a back and forth process between the patient and the clinician. And there are a number of practical steps. We might again know what shared decision-making is in theory, but to actually put that into practice is a little bit more difficult. And there are a number of steps. You invite the person firstly to participate in a discussion about the different treatment options. And then you present the options for the person. You discuss the pros and cons, what are the benefits, the risks. You assist the person in evaluating their options based on their values and their preferences. You facilitate deliberation and decision-making. You then check and clarify that the patient understood the discussion, and then you assist them to implement that decision that they've made. And we know that shared decision-making is is good. It can lead to better outcomes. And this was a Cochrane review where they reviewed a large number of trials across a whole range of different conditions, not just osteoarthritis, but looking at the outcomes from when shared decision making was used. And what they found that it did improve across a number of areas, improved patients' knowledge, reduce their internal conflict, for example, and importantly, up to 20% choose less invasive surgical options and more conservative treatment when a shared decision-making process is used. And there are a number of decision aids that can assist in shared decision-making. There are a number of these aids for osteoarthritis, particularly around joint replacement surgery. And I think that we should be looking for these and using these in our consultations because they do help to formalise, if you like, that shared decision-making process. We also looked at how we train clinicians in person-centred care because, again, as I said, we might know it in theory, but putting it into practice is not as easy. And this was one of our PhD students, Belinda Lawford, and she evaluated physical therapists who had taken part in training around person-centred care. And it involved a 2-day workshop. Then they had to go and practice and audit 8 consultations with 4 patients over 3 months, and then they came back to another workshop for audit and feedback. And what you could take from this is essentially it's not something you can do and learn in just a half an hour course or a half an afternoon course. It really is something that is a skill, and as a skill it involves practice. And so we really need to be embedding this into our undergraduate or our training programs for our clinicians so that right from the outset they are practicing in a person-centred manner, because it's much harder to undo the learning that you have and the way that you consult, and it's much easier to train the next generation of clinicians in practicing in a person-centred manner. The next topic I'm going to briefly touch on is contextual effects. And we know contextual effects, or we might know them as placebo effects, and we know that, that these effects are things that can come from our expectations, our learning, our emotions, our motivations, etc., and that these effects can all lead to symptom relief. And these are particularly important when we're dealing with chronic pain condition such as osteoarthritis. And I think for us, the real power of the placebo, or these contextual effects, was highlighted in a study that we did looking at physiotherapy for hip osteoarthritis. So we had 2 groups. Patients were randomised into the physiotherapy group, where they received your normal physiotherapy with exercise and manual therapy and gait aids, and they saw that the patients went to the physiotherapist on 10 occasions. The placebo group received, the physiotherapist put some inert cream on. It was just some hand cream, but they were told it was anti-inflammatory gel, and they had some ultrasound, but the ultrasound was turned off, and they also went to see the same physiotherapist on 10 occasions. And what we found was that there was no significant difference between the 2 groups. Both groups showed benefits for both pain and function that were clinically relevant. And so believing that a treatment's effective is a really powerful placebo or contextual effects, and going to see a caring therapist who chats to you and shows some empathy and listens is really powerful. And we know that these placebo effects, or these contextual effects, are present for a whole range of treatments, not just physiotherapy. And this was a systematic review looking at pain in osteoarthritis and the amount of the treatment effect that you could attribute to these contextual effects. And you can see that they're present across the board for surgery, for acupuncture, for drugs as well. And around 70% actually of the total treatment effect can be contributed to these contextual effects. So what we need to do in our practice is harness the placebo effect. We don't need to be apologising that that's there. We need to be harnessing it. And so that means we need to be really optimistic and create this positive expectation of benefit for the patient so that they really do believe that they're going to get some benefit from the treatment that you're giving them. We need to ensure that the physical environment is conducive and positive. It's really important, that rapport and that professionalism, which will all go into helping to maximise the contextual effects. The next area that I think is really important is self-management and behaviour change support. As we said, this is really the key when we're dealing with chronic conditions such as osteoarthritis. We don't want to be doing passive treatments and a lot of hands-on treatment. We want to be empowering the person to take control and to manage their own condition. And in osteoarthritis, and as for other conditions as well, chronic conditions, there's a whole range of behaviours that we're often asking the patient to change or to do something differently. We're asking them to do more exercise. We're often asking them to lose weight. In other chronic conditions, if they've got diabetes and heart disease and so forth, we're asking them to stop smoking. We're asking them to take tablets. So there's a lot of behaviour change that's required by the patient, and it can be really overwhelming. In our area, obviously, and we know that exercise is a key treatment in the management of osteoarthritis. It's a treatment that every patient with osteoarthritis should be getting. But we know that adherence to exercise over time reduces, and this is just the results from a number of exercise studies. And you can see they all basically say the same, that over time, adherence to exercise reduces. And we know that if you're not going to do your exercise, obviously you're not going to get the benefits from exercise. So, how do we maximise patient adherence to their exercise, and how do we get them to be more physically active? As I said, this is not easy. We all know ourselves that it's quite difficult to change behaviour. We've been using behaviour change theory to try and look at that in the context of our treatments, because obviously we can just think up out of our head something that might work, but it's better if we embed it into some behaviour change theory. And there's a whole range of different theories that are out there, but we've been using Susan Mickey from the UK, her behaviour change wheel methodology, the COMBI system, which basically says that behaviour occurs because of an interaction between three necessary conditions: capability, opportunity, and motivation. That's the COM, leading to B, the behaviour. So capability really is that the person has to have the psychological or the physical ability to be able to enact that behaviour. It's no good asking them to do exercise if they don't have the physical ability to do it, or psychologically they're not able to do it. Motivation is the reflective and automatic mechanisms that will activate or inhibit the behaviour. And then they also have to have the opportunity to do the behaviour. They need to have the physical and social environment that enables the behaviour. So, for example, they need to have the support systems or their family and friends who are going to help enable that behaviour. They need to be able to, if you're asking them to go off to the gym, obviously they need to have the gym nearby, the physical environment to enable that behaviour. And so in the context of this behaviour change wheel framework, we this is Fiona Dobson, one of our postdocs. She looked at what are the barriers and facilitators to exercise participation in people with hip and or knee osteoarthritis. And what she found, and she mapped them to this behaviour change theory, that there are a number of, quite a number of barriers and facilitators, but a lot of the barriers related to people's beliefs about the consequences of exercise and beliefs about their capabilities. So beliefs about the consequences were that often people felt that exercise wasn't going to be good for the knee because it was a wear and tear disease. So therefore, if you've got a wear and tear disease and your knee's worn out, you shouldn't be exercising. So it brings me back to that language that I mentioned before. So if the person doesn't believe that exercise is going to be beneficial, then that's going to be a barrier. Also, beliefs about their capabilities, that is their self-efficacy around and their confidence to exercise as well, was a barrier. But many of the facilitators related to reinforcement and feedback and so forth. So really what we found is that clinicians should be taking a proactive role in facilitating exercise uptake and adherence rather than trusting the patients to independently overcome these barriers. So we need to be working with the patient to help them identify what are the barriers and facilitators that are relevant to them, and what solutions do they think that they can come up with to help overcome them or to support their exercise efforts. Another study recently by Johnny Quick over in the UK found that both attitudes and beliefs predicted the amount of physical activity in people with chronic knee pain. So if they had greater self-efficacy for exercise and positive exercise outcome expectations, they were more likely to exercise. So in essence, if you believe that the exercise is achievable, safe, and likely to benefit the health-related outcomes, that appears to be really quite motivational. So there are a whole range of different adherence strategies that people could use, and it's a bit of a smorgasbord that you could work with the patient to see what's going to work for them. But there's actually not a lot of research to see what actually works. And Pip Nicholson, one of our PhD students, just published a systematic review looking at randomized controlled trials of adherence strategies for people with low back pain or osteoarthritis. And she found that there was some evidence to support different activities such as motivational strategies, behavioural graded exercise, behavioural counselling, action coping plans, and having audio video exercise cues, but also for booster sessions. So 2 studies, including one of our own, when you pull the data, it showed that adding booster sessions after a period of initial exercise can be effective in long-term adherence. So you might see the patient for the first couple of months, you send them away for 6 months, and then you get them back in again to have some booster sessions. We also looked at the effects of a web-based, app-based exercise programming system, and there's quite a few of these available, where you can actually program the exercise program for the person and send it to them on their iPhone or their iPad or their computer, and they can access it there, and it has nice videos of the exercises, and it gives the number of sets and reps that they need to do, and they can track their outcomes. And we looked at that in 304 people as a randomized control, randomizing people who had going to see the physiotherapist into using this web-based exercise programming system, or the usual method that the physiotherapist used, which was often things like hand drawings on a piece of paper. And we had people with a range of musculoskeletal conditions. And what we found was that those who had used the web app-based exercise programming system had significantly greater adherence to their number of exercise sessions than the usual methods group. And also they had less pain after the program using this particular system. So giving some evidence to support perhaps using systems such as this. There's also health coaching that's out there. It's often used widely to try and help patients gain the knowledge and the skills and the tools and confidence to become active participants in their care so that they can reach their own sort of self-identified health goals. So we were interested in looking at whether the addition of telephone coaching to a home-based exercise and physical activity program for knee osteoarthritis would be effective. So it was again a randomized controlled trial. We had 2 groups. Both groups went to see the physiotherapist for 5 sessions, and the physiotherapist gave them a home exercise program and helped work out a physical activity program for them. And the telephone coaching group additionally had 6 to 12 telephone coaching calls by a different telephone coach. And we were then looking at what effect that had on adherence. And we found that adding the telephone coaching led to greater adherence to exercise and increased physical activity levels compared to the group that didn't receive the telephone coaching, although both groups had similar improvements in pain and function. So you can increase adherence to exercise using methods such as telephone coaching, where the coach uses techniques such as motivational interviewing and so forth. So I think clinicians do need to be experts in supporting behaviour change, but I'm not sure what it's like over in the US, but over here, clinicians again don't get a lot of training in how to support behaviour change. So they're not really skilled in techniques such as motivational interviewing, decisional balance, where you help the person weigh up what are the pros and cons for taking up the new behaviour, or what are the pros and cons for staying doing what they've been doing and not doing the behaviour, so helping the person work through that. And they do need to have these skills so that they can support the patient to make the changes in their behaviour. And so it is important that clinicians actively work with the patient to identify the barriers and facilitators, and then the adherence strategies that are going to work best for them. And again, that comes back to person-centred care, where you're trying to work out with the patient what is going to work best for them, because it is going to be an individual process. I'm now going to touch on a biopsychosocial management approach. And we know that people who have osteoarthritis have a range of issues that cover both the bio, psycho and social aspects. So they have pain, they also have a range of physical impairments, muscle weakness and stiffness and so forth, but they also have a range of psychosocial issues. They are more likely to have depression, anxiety, fear. They're more likely to have catastrophizing, poor pain coping skills, reduced self-efficacy. And then all of these as well can contribute to functional limitations, which reduces their participation in vocational and leisure and social aspects and a lower quality of life. So really, we need to be taking a biopsychosocial approach to management if we want to address the whole person. So we've been very interested in looking at, well, how can we do that? As physiotherapists, we often concentrate on the exercise, but how can we embed some psychological interventions as well in management? And so we've been working over a number of years with Professor Frank Keefe from Duke University in the US there, and he's a psychologist and he's done a lot of work around pain coping skills training. But he had the psychologist delivering the pain coping skills training, and he was interested in working with us to see whether we could train up the physiotherapists to incorporate pain coping skills training into their management, and so that they could combine both exercise and pain coping skills training to better manage the patient. And we thought that that would have symptom, resource and practical advantages. The person wouldn't have to be going to see lots of different clinicians. It also meant that the physiotherapist could use the pain coping skills training while they were doing exercise as well to reinforce those skills. And back here in Australia, really not many patients would go and see a psychologist with their osteoarthritis. And so this made sense as a new model of service delivery. So we did a randomised controlled trial where we had 3 groups, all delivered by physiotherapists, and we looked at whether exercise plus pain coping skills training combined was more effective than exercise alone or pain coping skills alone. And they all went to see the physiotherapist for 10 sessions over 12 weeks, and then we followed up people over 9 months. And what we found, and this is for physical function, that the integrated group that received both had significantly greater improvements in function than both other groups at 12, 32, and also compared with the pain coping skills training group alone at 52 weeks. So you've got these additional benefits where you combined both the physical treatment and the psychological treatment. Another, I suppose, a biopsychosocial approach that we need to have is incorporating weight management as well. And so again, whose role is it to do the weight management? And this was a question that we asked around, well, is it the physiotherapist's role in weight management? And this was some qualitative work by Jenny Setchell and Kim Allison, one of our PhD or postdocs now. But they wanted to see, did the physical therapists think that they had a role in weight management in knee osteoarthritis or in osteoarthritis? And most thought, when we interviewed the physios, most thought that advising on weight was important and was something that the physical therapist should do. But they were very worried about stepping on the toes of the dietitians and these professional boundaries, and that they felt that they weren't skilled in the area and they lacked confidence in being able to talk to the patient about weight management or being able to support them in weight management. And this was asking the physiotherapist, this is just some of the quotes, and so the quotes from the physios, if I had to go any deeper, I wouldn't really. Like if someone asked me what should I be eating, then I'd struggle, like I could tell them vaguely. Someone else said, the patient might start to find it offensive if we talk about their weight as a problem. I don't feel like I've got enough tools and evidence base to discuss how weight loss might actually happen. And it's the interprofessional barriers and defining what we all actually do. So I think it is important because a lot of people here, again, don't necessarily go and see a dietitian, but we think that it is important to at least bring up weight and talk to the patient about weight. But that is something that is difficult for people to do. They don't want to alienate the patient by bringing up a weight discussion and doing it in a manner that might actually be stigmatizing. So I think that a lot of clinicians, GPs, doctors, allied health clinicians do need training in how they discuss weight with their patients. And so, as I said, having that conversation is not that easy. So how can we do that in a manner that's going to be conducive to change? So finally now, I just wanted to briefly touch on different models of service delivery. And again, over here in Australia, there's a lot of interest in how can we deliver care differently. Yes, we've been doing it traditionally in face-to-face, one-on-one consultations or some group consultations face-to-face. And there's been, they go to the GP and then they might get referred, or they can go to see the physio straight off. But how are some different models of service delivery that are going to be more effective, reach more people? So we've been interested in e-health for delivery of evidence-based treatments, because in Australia, a lot of people live a long way away. They may not be able to access care, they may not be able to access clinicians, or they may have mobility issues that make it very difficult for them to leave the house and go and see a patient and so, go and see a clinician. So e-health really does offer some scope for different models of service delivery. So we recently published a trial where we looked at the effectiveness of an internet-delivered treatment, and it comprised exercise and pain coping skills training for people with chronic knee pain. So the two treatments that were all delivered online was the physiotherapist prescribed home exercise program. So the physiotherapist talked to the patient via Skype, and then the patient did an online automated pain coping skills training program called Pain Coach that Christine Rinnie from the US there and Frank Keefe had taken their face-to-face program and put it online so that it could still retain those therapeutic elements. And what we found for both pain and function was that the intervention group had significantly greater improvements in pain and in function over the 9 months of the study compared to the control group who received online education only. And we also did some qualitative research where we talked to the patients about how they found it. And they said things such as, well, I think that's the way the world is moving, to be honest, and instead of wasting half an hour driving somewhere and then finding a car park and the costs involved. So there's a lot of very positive feelings from the patients and the physios about this method of delivery. And this person said, I felt, this sounds a bit crazy, but it was almost more personal than in the past. The therapist was coming to you, so via the computer, so I felt more personal using the electronic communications, and almost, this is an indictment on modern society, you feel more comfortable using electronic than you do face-to-face, but it almost felt like that. The therapists also were very positive in the end. Initially, they were sort of skeptical. They wanted to put their hands on, but they then saw the benefits, and they said things such as it was good to be able to see them doing the exercises in the environment that they're going to be doing the exercises. You can set them up, you can make sure they're going to do it correctly, you can really troubleshoot. Someone else said, I did feel that it was quite easy to make a strong connection to the patients because they were in their own environment, and that made it better for me as a physio. And a lot of the patients said that they felt that there was this power shift, that they felt like they were in control rather than the physios being in control, because the physio was coming to them in their home and not the other way around. There's also other ways that you can deliver care online. And so, for example, we've involved with Arthritis Australia have a program called My Joint Pain, where patients can log in, they can get a lot of information about different treatments, they can do some decision aids, they can set up a treatment program, they can follow their progress and so forth. So a very interactive program that patients can use, and it can be an adjunct to clinician delivered care as well. And we did a study and we found that following 12 months of use, significantly greater improvements in self-management and weight loss in website users compared to non-users. Another study that we've been doing, led by Professor Rana Hinman here at our group, is looking at, we called it the Telecare randomised controlled trial, but it is looking at delivering exercises via the telephone. So this time not Skype where you can see the patient, but simply the telephone, because patients may not necessarily have access to the computer, but most of them will have access to a telephone. So we're looking at a telephone-delivered physiotherapist prescribed exercise embedded into an existing nurse-led musculoskeletal helpline run by one of our consumer organisations. And again, that's showing very positive results. We haven't analysed the data yet, but from the qualitative research, people are finding that it is useful and something that they can do anywhere. And just finally, another model of service delivery that we're currently looking at is where we're focusing on the GP. So there's training for the GP where they are going to concentrate on the core behaviours and particularly around exercise and weight loss. And then they're going to refer to this remotely delivered service, which is the care support team. And they can give the service over the telephone or via Skype. And it's again around care planning, exercise, weight management and self-management support. So again, trying to make it more accessible to everybody by being remotely delivered. So that there are some issues around how do we roll out these new models of service delivery. We need better evidence to support that these are effective. We need different skill sets for the clinicians. There needs to be some training in how you deliver care on the telephone or via Skype, which is very different from face-to-face. We need to know whether they are going to be acceptable to patients and clinicians. There's issues around privacy and security, issues around funding, who's going to fund them, and what about insurance for the clinicians who are delivering care in this manner. So there are issues to be resolved. But I think this is the way to go, where we need to be thinking at how we can deliver care differently. So in summary, chronic conditions such as osteoarthritis require a greater hands-off approach and a much more approach there where we empower patients. Education plays a key role. We need to upskill our clinicians in patient-centred care and behaviour change support. And I think it's really important to be exploring, as I said, different models of extending the scope of practice of different clinicians. Just because that's how it's always been traditionally done, we need to be looking at extended scope of practice and different ways of delivering service, including e-health. So thank you for your attention today.
Thank you, Dr. Bennell. That's a very interesting presentation, and I think hits on so many things that we talk about at the Alliance with trying to get people to engage in behaviors on their own, just like you've discussed, physical activity and weight management and education and all of the things that are challenging for even healthy people, let alone folks who have pain and struggle to accomplish some of these things. Earlier in your presentation, just as you were getting into the issues around capability and psychological ability and motivation and so forth, you had you quickly showed a picture of a woman holding 2 dumbbells, and you were talking about how language matters, but it sort of struck me, I think pictures matter as well. And here's a woman, who is a little bit older in age. So often you see folks who are young and fit, and perhaps people don't visualize themselves as being able to do these things.
Yeah, no, very good point. And I think, yes, language and visuals is really important. I also think patient stories are very powerful as well, or patient narratives. And so including those and listening to what other people say, I think is, as you said, very powerful as well.
Do you find in terms of educating patients that part of that is in re-educating patients on what it means to have osteoarthritis and how the disease actually progresses, or is that less of an issue for patients and you really want to get to the behavior?
No, definitely. And I think people have their own opinion of what osteoarthritis is, or their neighbour has, someone they know has had to have a joint replacement. So they often think that once they've got osteoarthritis and they've been diagnosed with that, it's just an inevitable pathway. They're going to get worse. They're going to have a joint replacement, and there's nothing much they can do. It's just because they're old, or they've been told that you're getting old. What do you expect? And so it again is changing the perception and using language and saying things such as, osteoarthritis. Most people actually don't progress. Only about 1/3 of people with knee osteoarthritis, for example, will actually show progression of the condition. So most people will actually not progress, and that there are a lot of treatments that can be effective and that you can try and that you can find is very effective. And also, what you see on the x-ray isn't actually related to how people function. And so, we now actually emphasise that x-rays aren't needed, and the guidelines that are coming out now are all saying that in the majority of cases x-rays are not needed to diagnose osteoarthritis, and it should be made, the diagnosis should be just made clinically. And I think that's a good thing, because it takes away from the person looking at that x-ray and just seeing something and thinking, oh, that's, I can't make that better, there's nothing I can do. So if you don't have the x-ray and you're not focused on that. You're focusing on what it means to the patient. What is it doing to your function? What's it doing? How's the pain? What can't you do? Let's then work toward improving those things. And I think so that makes a big difference as well. So certainly being optimistic, because again, there's been this bit of pessimistic, there's nothing they can do. So being optimistic about what they can be doing about it, that there are lots of effective treatments, that they not necessarily going to progress, and most people don't progress, and that we're going to be working on how it's affecting you. So I think that's really a very powerful message. And as I said, I think spending a lot of time getting the patient on board around education and information is really important.
I agree. I think that's a great point. And, I'm not sure how things work for you in Australia clinically, but I know certainly here in the States our general practitioners, primary care physicians, and so forth really have so little time in the clinic that the education is often limited. And I think it's a great role for physiotherapists, physical therapists, occupational therapists, for those types of folks. Because I agree with you when you said in your talk that people with osteoarthritis are not necessarily going to go see a psychologist for that. They may not see a dietitian. So I think there is a role, as you described, for some of the other healthcare providers to fill that educational space.
Yes, definitely. And also the consumer organisations, so that we have resources that are evidence-based and, as I said, have the right language to them, and are all saying the same message. Because it's funny, you even look at some of the information on websites and so forth, and they're still reinforcing some of these messages and misconceptions that we actually want to be changing. So I think that's a really big part as well, and so that the patients have a lot of resources to utilise.
I agree. Yeah, we're trying to embrace that in the Alliance, trying to change some of the language, so I get that. One last question is, you had talked about, obviously, many modes of delivery with the online programs and looking at physiotherapists and apps and things like that. Do you also have community-based programs, evidence-based programs out in the community that you can refer to, or how does that fit into the scheme?
Yes, there are certainly programs that people can do as groups and go and see. We do have some self-management programs. There are a lot of barriers for people going to the self-management programs. So I suppose that's why we've been looking at different modes, but there are, YMCA have water exercises and other exercise programs. So I think, again, it's knowing, particularly for clinicians, knowing the resources that are out there in your area, so that you can give patients choice. Because for me, it is all around choice. It's not us telling them you should go to water or exercise. If the person doesn't even like water, they're not comfortable going into water or putting on a bathing suit. So it's talking to the patient. What is the form of exercise that you're going to like to do? What things interest you, and coming up with strategies with them. So I think, as you said, knowing about all the resources, community resources that are out there is really important.
Well, thank you very much. I appreciate you are taking the time today and sharing some of your great research with us. So if any of our listeners have any questions, I will send them off to you.
Thanks, and I apologise for the dinging. That was my computer telling me I've got email, but I couldn't seem to turn that off.